This meeting is now being recorded.
Well, again, good evening. My name is John Furman. Welcome to the EDS Awareness Educational Series webinar. Before we get started and introduce our speaker, I just wanted to give you a general overview of our free program for those attending for the first time. So generally, we'll talk about who we are, what is our program, some upcoming events. We'll then introduce Dr. Maitland, our speaker for this evening, and we'll have a Q&A session. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 60 groups to date. Each group is given their own free website with a link from the directory and the map. In July, we attended as a sponsor at the EDNF conference for the third time. There was a great response for our program. We are adding a number of new support groups in the U.S., 2 in Australia, and there's going to be a new one in UK and New Zealand. So we received feedback from the conferences that the conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Wednesday, typically at 7:30 Eastern Standard Time. All the programs are free. The meeting announcements and where possible the webinar recordings will be posted on our site at edsawareness.com for future replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Score, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for this program and usually covers our monthly web fees. So please visit the store and check out the helpful products that we sell. So just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you are having medical problems now, please call 911 and get the services that you need. Always consult your doctor before making any changes to your treatment.
Upcoming events include the New England Marfan Syndrome and Connective Tissue Disorders Symposium, which is on September 3rd, and Dr. Hal Dietz and Dr. Brad Tinkle will be speaking at this conference. The speaker for our webinar in September 20th is Dr. Richard Barnum. Dr. Barnum is a psychiatrist, and his topic is psychiatric illness and EDS, connections and confusion. The presentation will also address misdiagnoses that some of us have seen, such as hypochondria or conversion or somatoform disorders. A reminder, after tonight's presentation, there will be an opportunity for Q&A. Add your questions at any time during the presentation by clicking on the Q&A icon located at the top of your screen. After typing in your question, click the orange button to submit. Our speaker tonight is Dr. Ann Maitland. She will talk about allergies and mast cell activation syndrome. She spoke at the EDS conference this year in Houston. Dr. Maitland is board certified in allergy and clinical immunology. She is an assistant professor at the School of Medicine at Mount Sinai in the departments of otolaryngology and clinical immunology. She is the medical director for the Comprehensive Allergy and Asthma Care, as well as the new Mast Cell Activation Center of New York. Dr. Maitland completed her doctorates in medicine and philosophy at the University of Pennsylvania, her residency at Brigham and Women's Hospital, and her clinical immunology training at Mount Sinai Hospital. She has been recognized for her clinical excellence at Mount Sinai and as a New York Times super doctor for the past 4 years. She now focuses on the diagnosis and treatment of primary immune deficiency and hypersensitivity disorders, including the emerging spectrum of mast cell activation disorders. So at this time, I'd like to give a warm welcome to Dr. Maitland. We're looking forward to your presentation, and you should see her slides loading on the screen now, and I'm going to go ahead and turn over the microphone to you. Welcome, Dr. Maitland.
Good evening. Thank you, John and Deanna. You guys have been extremely supportive. I am a newbie at doing webinars, so I'm going to treat this as a free-flowing discussion. I welcome any questions. I'll try to answer them to the best of my ability. And I want to talk about a hypersensitivity condition that is as underdiagnosed as what I'm hearing from my patients and what I'm sure most of you are experiencing in the community who have connective tissue disorders. So we're going to be talking about mast cells and how they might be misbehaving, especially in individuals that have connective tissue disorders. So I want to talk about two patients. This is the first patient that I met who really kind of opened my eyes regarding the ability for mast cells to misbehave in individuals where allergy testing has been completely negative. This is a little boy who, first day, he was very rashy, he was very colicky. He had underwent testing to various foods and really showed no improvement. Then he started developing congestion issues. He had asthma exacerbations, and he also had a few anaphylactic reactions where he either had cardiovascular or respiratory compromise. By the time I met him, he was on 6 foods, and his parents went to extreme changes in his environment in order to reduce exposures to allergens as well as irritants. By the time I met him, as a 4-year-old, he had seen 10 allergists, 4 gastroenterologists, 4 orthopedic surgeons, 3 geneticists, 2 rheumatologists, 2 endocrinologists, 2 nutritionists, 2 physical therapists, a cardiologist, a neurologist, and a pulmonologist. And all the mother could say was she stumbled upon me, and essentially I was just willing to listen and try to put some pieces together. And I have to say, when it comes to taking care of individuals that have mast cell disorders, I was taught a long time ago by Mariana Castells as well as Albert Scheffer that it's really important to elicit the story because the patients will tell you what's going on. It's your job to kind of put the pieces together. This is a patient that I met not too long ago and actually was doing quite well until about 7 months ago. She had a really bad stomach bug, and then she just kept on having recurrent episodes of nausea and vomiting, especially around her menses. Again, she had underwent evaluation by several different specialists who still could not figure out what was going on with her, and without a good working diagnosis, she again continued to have ongoing symptomatology and only came under control once she got evaluated and received the diagnosis of mast cell activation disorder. So as you can tell from this title that was just released over the summer, mast cell activation syndrome is a newly recognized disorder. And to be honest, we have appreciated as a medical community allergic disorders for over 30 years. However, as you're going to see, hypersensitivity is more than allergy, and allergy is definitely more than IgE, which you may detect either through testing, skin testing, or blood testing. And within the past 3 to 4 years, we really have been able to crystallize the fact that a lot of these allergic reactions are really just mast cells who are inappropriately releasing factors that modify the environment. And depending on where these factors are released, you will experience symptoms. So before I get into what mast cells can do and how they misbehave and can cause a lot of symptomatology, I think we need to understand what the job of the mast cells are in the first place. And mast cells are part of our immune system, essentially our defense against the environment where there's a slew of germs and toxins and chemicals that mean to do us harm. And just like we as a nation have different types of armed forces to meet different types of dangers and respond to those dangers with the best of our ability, so does the immune system. In the immune system, it has been basically evolutionarily broken down to the innate immune system, which can be found in every multicellular organism, and the adaptive immune system. And the reason why I put this slide now is to let you know that when it comes to looking at the mast cells, most allergists, immunologists, and most practitioners focus on antibodies that are part of the adaptive immune system. And if there are positive tests, it can infer that the mast cells are active. But to be honest, if you want to figure out whether or not the mast cells are misbehaving, you need to go where the mast cells are located. And these are not blood-borne cells. These are cells that are situated in the tissue, doing their job, trying to protect, as you'll see in the next slide. Essentially, these are first responders who are originally born in the bone marrow. And they get their marching orders once they've received some essential training saying that you're going to be a mast cell. And they get chemical mediators from the organs that need the help. So the spleen, the lung, the intestine, the skin, the respiratory tract, all release chemicals saying we need more mast cells. The mast cells go to the various tissues, and basically they further differentiate or acquire the skills that are needed to basically act as guards or sentinels in those different organ systems. And although they are all mast cells, those mast cells will have overlapping but unique properties for the organs that they're trying to serve. That being said, there are some mast cells that have some chemicals that are useful in the skin that you might not necessarily find in the gut or the respiratory tract. And by the way, if there's acute inflammation going on, such as in joints, mast cells can be recruited as well. And there's been a wonderful researcher out of Brigham and Women's who actually showed that in the joints of individuals that suffer with rheumatoid arthritis, mast cells are in increased number and quite activated, contributing to ongoing symptomatology in individuals affected with that autoimmune disorder. So I use this slide to kind of emphasize that mast cells really are kind of like the first responders. They kind of stand behind the wall of the skin, the gut, and the respiratory tract, these three organ systems that are chronically exposed to the outer environment, basically trying to see whether or not if there's a break in the wall, they need to respond to that break to see whether or not this is a organism or chemical that might pose danger to the body. So, and you can see that there are various insults that can happen that can recruit mast cells into action. So you can have physical trauma, whether it's a penetrating wound, a burn, and in some individuals, just pressure will cause mast cells to activate. They're also, their main job is actually to protect us against parasites. And the antibody for what we think has been going on for years, I hope I don't lose this program. Okay. My computer just kicked out the program. Let me go back on again. Okay. Pardon the, I love Windows 8, can I tell you?
We understand. We've had issues before with the computers, so appreciate your understanding, and we can continue.
No worries.
on when
It's
you're
kicking
ready.
back up again. I just thought it's a temperamental machine.
Understood. Yeah.
Okay, I'm coming back.
Oh, yeah.
But as it's coming back on, what I wanted to point out with this slide was the fact that these mast cells can be, let's see if they will allow me to advance. These mast cells, I think it's not going to allow me to advance. Okay, while I'm playing around with the controls, in this slide, oh, there we go. How'd that happen? Let's see.
I can switch the slides for you if you'd like.
Okay, if you can take me back to the previous slide, that'd be great.
Okay, I'll do that.
Okay, so here they have antibodies called IgE that can recognize parasites, and this basically allows the mast cells to take a mugshot of this organism, saying, "I've seen you before, so now I can recognize you much more swiftly and eliminate you." And as you can see, there are different names of receptors that are on the mast cells, which really allows the mast cells to respond to different dangers very quickly. So the TLRs have different receptors that can recognize proteins that are unique to viruses or bacteria. Oh, perfect. Thank you. Thank you, John.
Okay.
These mast cells have the ability to respond to changes in UV light or temperature, so it's not unusual for individuals that may have cold or heat to have like allergic-like reactions to even changes in the temperature. What's also very interesting in individuals that have misbehaving mast cells, they can actually have really large local reactions to insect stings or bites, whether or not it's a mosquito or a wasp or even snake venoms. So these are all kind of clues that if the mast cells are misbehaving, they might be much more sensitive to non-allergic triggers that don't have, and what I mean by non-allergic, they don't have IgE that we can detect either through skin testing or blood testing. Another reason why I like this slide is it shows you that as one body, we have the ability, the mast cells have the ability to talk to the nerves, they have the ability to talk to the blood vessels, and they have the ability to recruit in other immune cells if they perceive a danger that they need more help. So these cells, as first responders, really are kind of like major regulators in our defense against perceived dangers. And if it is a bacteria, a virus, a parasite, or venoms, that is an appropriate way of activating the cells and recruiting all the chemicals that they can release. If it is apples or your cat or just change in temperature, that is an inappropriate activity, and that's considered a hypersensitivity reaction. And what we find in individuals that have either too much IgE running around, which binds the mast cells, or if they have connective tissue disorders, which we're starting to appreciate, these cells seem to be a lot more twitchy. They're a lot more easy to activate inappropriately, which then can cause chronic symptoms such as we're going to discuss a little bit further into this talk. So over the past, I would say, 30 to 40 years, we have seen a huge increase in inflammatory disorders. Whether you're talking about autoimmune disorders like Crohn's disease or multiple sclerosis or type 1 diabetes, or hypersensitivity disorders such as food allergy, allergic asthma, or allergic eczema. And interestingly, that corresponded with decreases in disorders where we think the immune system should be appropriately activated, such as tuberculosis or these viral infections such as measles or hepatitis A. And we think because we have so changed our environments, what we eat, how we medicate ourselves, what we breathe, where we live in, the immune system is no longer preoccupied with these infectious insults. And it's almost like having an army that's been at battle for thousands of years, no longer having to focus on these items, now they start misfiring against self-tissue or at innocent particles that then they start releasing these chemicals, and that's a hypersensitivity reaction where the mast cells essentially start discharging their chemicals when they see whatever you might be sensitive to. And I have to tell you, we have patients come through our doors all the time saying we're allergic or we're sensitive. And depending on where these cells are misbehaving, it can cause sinus symptoms, it can cause skin symptoms, it can cause gut symptoms. And since mast cells usually populate the gut the most, the skin second, and the respiratory tract third, this is where individuals that have mast cell activation disorders will present more commonly. So basically, mast cell activation disorder means that the mast cells are inappropriately activating. And like I said before, they have a tendency to affect the gastrointestinal tract, the skin, the respiratory tract. But these mast cells can be recruited to other organ systems as well. As I had said before, we know that they can be recruited to the joints. They've been known to be recruited to the uterus and also to the bladder. And their impact has also been shown in the peripheral nervous system as well as the central nervous system. So essentially, mast cells can misbehave in lots of different organ systems and really can show a spectrum of disorders. And to try to figure out whether mast cells are misbehaving or not, we need to see whether or not there's an increased number of mast cells, which we see in individuals that have what we call clonal mast cell disorders, meaning that there's something broken within the mast cell that causes them to be overactive, or what we're mostly seeing in individuals that have either immune-mediated disorders such as too much IgE. This is an antibody that we use to test for sensitivity to cats or dust or foods or medications, or have autoimmune disorders where they're inappropriately being recruited in, or individuals that have physical triggers, which might be the predominant action going on in individuals that are affected with connective tissue disorders. So essentially, is it something broken within the mast cell itself, or is it something broken in the environment and the mast cells are just being a good soldier, appropriately responding to inappropriate triggers? So I've grabbed these headlines or from movies to show that classic allergies, meaning we're able to find this antibody called IgE to either airborne or food or chemicals, has been on the rise for the past 20 years. Both these Time magazine articles were in the late 1990s showing that allergies, which affect the nose and sinuses, skin disorders such as hives or swelling, asthma, which has really been in the rise in lots of different communities. And then for some individuals where they are exposed to something that causes the mast cells to affect either the respiratory tract or the cardiovascular tract severely to cause what's called anaphylaxis. So let's talk a little bit about what allergies mean. So when someone says the term allergy, that means we're looking for the presence of an antibody called IgE. Now, prior to us having asthma and allergic eczema and atopic dermatitis, this antibody was extremely important for fighting off parasitic infections. But like I said, we have so changed our environment, parasites really aren't as much of an issue now. So basically, we have mast cells that have been designed to fight parasites for thousands of years, and now they really don't have much to do. So this antibody essentially starts to recognize something that it doesn't. And the reason why I use this slide is I want to show you the difference between something that acts as an irritant as opposed to something that acts as an allergen, meaning you're able to detect IgE through testing or challenge. So if you take Clorox, for instance, and apply it to your skin, that is going to cause a lot of problems. It's going to irritate you. It's going to cause redness, pain, possibly itch. However, if you dilute Clorox down in a pool, like 1 to 1,000 or 1 to 10,000, it really shouldn't bother you as much. The difference between an allergen versus an irritant is that an allergen, whether you do it straight or dilute it down tenfold or dilute it down 1,000-fold, you can see that even if it's significantly diluted down, you'll get a significant allergic reaction. So allergists, what they'll do to see whether or not you're allergic to something, will take a little piece of that apple or the peanut or grass pollen, apply it to your skin, and if you get, and it's diluted down anywhere from 1 to 100 to 1 to 1,000, and if you have a reaction, this will tell me you have IgE sitting on mast cells that causes that reaction to happen within seconds to minutes after exposure. Now, this is focusing on IgE-mediated reactions, meaning that you've encountered cat or dog, and this gentleman that underwent skin testing or pollen. What happens is the allergens come down, they bind to the IgE sitting on the mast cells, and within seconds you have release of chemicals like histamine, tumor necrosis factor, which has a lot of impact on surrounding connective tissue, proteases, which can also affect the connective tissue, and heparin, which can actually, and all of us know as a medication that we use in hospitals to try to reverse certain types of clotting disorders. But the heparin is to loosen up the blood so it can come into the area and help. So essentially, when you encounter an allergen, this is like a false alarm, causing the mast cells to degranulate and release these substances. And in individuals that have rhinitis, for instance, if they go over to a friend that has a cat and they're allergic to cat, they might start sneezing, have nasal congestion, itchy, watery eyes, runny nose, sneezing, coughing. Then within minutes, it starts making more substances which have the ability to affect other organ systems. Like this can actually cause your lungs to start coughing or wheezing or constricting down. And then the mast cell is kind of like a patrolling officer who sees something that they don't like. They'll start to investigate. They'll start to release some chemicals to try to figure out what's going on and whether or not they need help, but then they're going to call for extra help. So basically, if the mast cell is considered a patrolling, officer who's working around the neighborhood, the cells that get called in are the eosinophils. They're the equivalent of the SWAT team because these eosinophils have really potent chemicals that have the ability to punch holes in parasites. But if there's no parasite in here, what happens is all these chemicals start doing local damage to the tissue where the eosinophils have been recruited in. And typically what allergists do, if you come in saying you've had a reaction, we'll test you to whatever likely substance you might have encountered, whether it's an airborne substance, and what we typically test for with airborne is like different types of pollens, different types of indoor and outdoor molds, animal dander, including cat and dog, components of dust, and I'm sorry for some folks who live in urban areas, cockroach is a huge allergen as well. We have the ability to test for certain foods. In this country, peanuts, tree nuts, milk, egg, soy, wheat, soy, and shellfish and fish are big allergens in the United States as well as in other industrialized countries such as the UK. Typical medications that we test for typically is penicillin, amoxicillin, and ampicillin. Those can be readily tested. We actually do allergy testing to certain insects, including mosquito, stinging insects such as yellow jacket, wasp, hornets, and fire ants for those that are living in the south and southwest. And then also there's some chemicals, and these are actually quite important for individuals that might have occupational exposures. For instance, those that work in the food industry where they might be exposed to airborne food products, whether you're talking grains. I have one gentleman who actually was a baker who had problems with the baking, the yeast that's used for baking as well. So by just putting it on your skin or getting some blood from the individual that we suspect, we can then put it in a test tube and test for these things as well. But I have to tell you, skin testing has a tendency to be a lot more sensitive than blood testing. There is a false negative rate of about 20%. And the issue in individuals that have connective tissue disorders, sometimes just pressing on the skin, which is also called dermatographism, can cause you to well up, meaning these cells are so sensitive, just a little bit of pressure will cause them to start releasing these chemicals. So I just talked about different IgE-mediated mast cell triggers. Let me talk about non-IgE mast cell triggers, meaning everything else that won't recruit in an antibody that sits in these receptors on the cell. So as I said before, just mechanical pressure can activate these cells. So some individuals have problems with what's called immediate pressure or dermatographism, meaning I have the ability to write on your skin. Some people have delayed pressure. I see this in women more than men, where they might be wearing tight-fitting clothes, such as undergarments, where after a few hours you start breaking out in hives, where the undergarments are constricting the skin. Some individuals have issues with if they carry a bag on their arm and the pressure on their arm lasts for more than 20 minutes or so, they might break up in hives as well. We have some individuals that have immunodeficiencies, where they have problems fighting off infections, and what I think happens here is they don't have enough antibody to fight off the bacteria that they might be exposed to. So basically, the mast cell sees that there's a bacteria, but it doesn't have the proper tools to fight it off, so they start releasing whatever they can. It's kind of like, I've used the analogy of a police officer showing up to a fire. You know, it's nice that the police officer is there, but they really can't help you as well as a fire person, fireman or firewoman. So basically, you have these chemicals being released inappropriately just as a compensatory but inadequate response to individuals that can't fight off infections very well. We actually do have some individuals that have developed an autoimmune response, like they developed an antibody against the mast cells. So no different than somebody who develops an antibody against their thyroid, that's an autoimmune thyroid disorder. If you develop an immune response against your gut, that's inflammatory bowel disease. If you develop antibody to your joints, that's an autoimmune joint disease such as rheumatoid arthritis or psoriatic arthritis. In some individuals, I said that they can be very sensitive to insect stings. It's not uncommon for a lot of the people that I'm meeting, both young and old. They'll complain of large local reactions to insect stings or mosquito bites. That's also indicative or at least suggestive that the mast cells might be misbehaving more than they should. We have individuals that are very sensitive to physical triggers, and that could be either vibration, heat. Some individuals, you might have seen a few articles about allergy to the cold. There was a story in Good Morning America, as well as the Daily News here in New York, of a young lady in Ohio who would swell with exercise, and she was I believe, a lacrosse player. She had to retire because every time her body heated up too much, she would swell and occlude her airway. And I'll show you a picture of her in a few minutes. We have some individuals who are just really sensitive to medications, and I think many of you might appreciate this if you've ever received any anesthesia and you just have very weird reactions to anesthesia. This might be also indicative that the mast cells are just really, really sensitive. Certain antibiotics, especially vancomycin, polymyxin is another one that's a topical antibiotic. Even some individuals with penicillins or cephalosporins to treat infections, they can directly activate these cells, and we don't really understand the basis of it. But the real big offender is aspirin. Aspirin and other nonsteroidals such as naproxen, ibuprofen, diclofenac, they have the ability in some individuals to directly activate mast cell subsets and become symptomatic. And then what's really interesting with people that have mast cell activation disorders, they can either present with hypersensitivity, immune deficiency, autoimmune phenomena, and also bleeding issues. Because these cells have the ability to release histamine, they can cause thinning of the blood, and if there's trauma, then you might end up with what we call ecchymoses or bruises, because basically the mast cells have made the blood vessels a little bit more fragile. So this is kind of a summary slide by one of our Canadian colleagues, Estelle Simons, who's up in Canada, basically showing that individuals that have allergic triggers, and again, foods, medications, certain antibiotics, especially like the penicillins, insect stings, latex is another big offender, we're able to detect the presence of IgE that sits on the mast cells, and that kind of gives us an idea that you have an IgE-mediated mast cell activation disorder. But in individuals that have allergic disorders, you might have a lower threshold to kick off these type of hypersensitivity allergic reactions to non-allergic, non-IgE-mediated reactions, including exercise, cold air, humidity, certain medications, especially, again, the non-steroidal anti-inflammatory agents, including some of the opioids, such as morphine and Dilaudid and codeine, can also cause direct activation of this. And then we have the activation of mast cells, which are the tissue-borne cells, or basophils. And to be honest, this is such a small population, I have to say that the medical community is a little bit behind on appreciating the role of basophils. But one thing I want to point out here, when it comes to testing for mast cell activation disorder, these factors that get released within early activation of the mast cells, such as histamine or tryptase, or these enzymes, which we don't commercially measure out in the community, they're transient. So, and you have to ask for these tests. And here's the thing. Some mast cells have tryptase. Some mast cells have tryptase but don't release it under certain allergic reactions or hypersensitivity reactions. So you really need to keep an open mind to try to diagnose mast cell activation disorder, and I'll get into more details in the next slide. You can also look for elevation of prostaglandins to see whether or not mast cells are misbehaving, and you typically look for that in 24-hour urine collections. You can also look for increased chemical mediators that promote mast cell growth and also recruit in the eosinophils, which I mentioned earlier. That's indirect evidence that the mast cells are misbehaving. But in order to diagnose mast cell activation disorder, if you don't get any answer from blood work, you need to go into the organ where you're having the most problems and assess the mast cell action within the skin, the respiratory tract, or the gut. Very difficult to measure it in the heart and especially in the brain. So we've gotten information from various studies looking at anaphylaxis and in individuals that have the clonal mast cell activation disorder, meaning they either have mastocytosis, where there is something broken within the mast cells that's causing the mast cells to be overactive, or monoclonal mast cell activation disorder. And from those studies, we're able to see that not only individuals that have anaphylactic-like reactions, and what I mean by that is, and actually let me take a step back. So anaphylaxis just tells me that you've had a trigger start in one part of your body and another organ system gets involved. And there's a range of reactions. We have individuals that might just have hives all over their body or swelling in their throat or in their tongue, but you can see that all these different organ systems can be involved in somebody who's having a anaphylactic reaction or a mast cell activation event. So I have to say that the individuals where we see this more readily in the medical community is if you have skin involvement. And I want to share a personal story in that my son, who has bad nut allergies, and his IgE to peanut is off the hook. His pediatrician did not think he had peanut allergy because he doesn't have any skin symptoms. My son, if he eats nuts, he just has gastrointestinal distress. He just starts vomiting, he just feels washed out, and then he has to go to the bathroom. So just because you don't have any skin symptoms does not mean you do not have mast cell activation syndrome. It just tells me that the cells that are most sensitized in my son, for instance, is in his gastrointestinal tract. Looking at individuals that either have anaphylaxis, mast cell activation syndrome, or mastocytosis, we see that skin is the most commonly involved or commonly diagnosed organ involvement. And you can either have hives, which is also called urticaria, itch, flushing. You can have swelling as well, which is the deeper part of the skin. You can have airway involvement. You get more congested. You find phlegm in the back of your throat. You feel that your throat is tightening or actually swelling. In your lungs, people might start to wheeze or start to cough or feel they just can't get a good breath in. Some women end up with uterine cramping. I've had one woman who underwent an allergy shot, and her allergic reaction actually caused uterine cramping and swelling of her labia. What's most commonly known is where you start dropping your blood pressure. And it's not uncommon in the emergency department, especially in young people, to misdiagnose anaphylaxis because they'll have a normal blood pressure. However, they're maintaining that normal blood pressure with a really fast heart rate. So if you're having episodes of feeling dizzy and your heart is racing, that tells me that something might be going on with your cardiovascular system and it needs to be addressed. Also associated with that is individuals that may have a weak pulse, have episodes of dizziness or near fainting or fainting itself. A major complaint, which is really underappreciated, and I look forward to hearing the webinar later this month, is what happens in the head. So a lot of people might complain of an impending sense of doom. They have a sense of uneasiness. They have cognitive defects, like they can't remember as well. It's difficult for them to formulate or address or simple addition, multiplication, word finding. They might find that they'll have visual changes. They'll complain of headaches. And in a lot of ways, it's almost migrainous because you're having such a change in the blood flow in the brain's not liking it, and you might either have headaches. I used to have a history of ophthalmic migraines where I would just lose my vision. All of these are suggestive of mast cells misbehaving as well and having effects of the central nervous system. And then I already spoke about the fact that, and there's been data showing that individuals that suffer with irritable bowel syndrome, which in my opinion means it's more like idiopathic, like we just can't figure it out. There was a couple of studies that have shown individuals that have been diagnosed with irritable bowel, meaning they have diarrhea, constipation constantly. They've been negative on endoscopy, looking for gluten allergies and what have you. If you go ahead and biopsy and then stain for mast cells, you'll see that the mast cells are misbehaving. And so there might be a close tie for mast cell disorder in the gastrointestinal tract contributing to irritable bowel syndrome symptoms as well. So Dr. Hamilton, who had an article in the allergy literature about a year ago, basically commented to the media that mast cell activation syndrome is easily treated if it's recognized. That means you have to ask the right questions in order to figure out whether or not somebody might be affected by misbehaving mast cells. And so his comment was patients with mast cell activation syndrome frequently go undiagnosed for years. But once accurately diagnosed and treated, the response is likely to be excellent. And we have lots of different treatment options available, but that can't happen unless you ask the right questions. I can't tell you how many patients I have met over the past 2 years who say I stumbled on Benadryl, or, you know, I was given steroids and I felt better. These are all mast cell suppressing agents. And when it comes to the diagnosis of mast cell activation syndrome, it's your symptoms, it's your response to treatments that we know that control mast cells, and then it's getting the appropriate lab data to kind of reinforce what we get from your story. So going to the different flavors of mast cell activation syndrome, it's generally broken down to, are you having increased accumulation and proliferation of mast cells in an organ system, and understand they can misbehave, and it could be in your skin, which is easy to diagnose in the form of mastocytosis, causing like little collection of mast cells in your skin, but also understand that these cells can accumulate in your gut, they can accumulate in your respiratory tract, and they can accumulate in your bone marrow. Then we have individuals where we know that the mast cells don't have something broken within them, but there's something in the environment that's causing the mast cells to activate. And I use these two slides. These are electron micrographs of a mast cell. So you can see that this mast cell has all these little circles. These are like little sacks of chemicals. And once the mast cell is triggered, you can see it just dumps all these chemicals. It's a much more angry-looking cell because it's on attack mode. And this can happen for various reasons, and I believe I talk about that in the next slide. So the question is, do you have mast cell activation syndrome? So what signs and symptoms are worrisome from mast cell activation syndrome? Hives, swelling, flushing, itch of the skin, runny nose, postnasal drip, susceptibility to upper respiratory infections like pharyngitis, tonsillitis, sinus headaches. Do you have asthma? And I have to tell you that this is a condition that we as a medical community do not screen for. And about 1/3 of individuals that have asthma involvement of their lungs go undiagnosed, and if they are diagnosed, they're undertreated. So I really implore all of you, if you are having issues, if you're tired, it is worthwhile getting a breathing test to see whether or not your lungs might be involved. Asthma can be as silent until you have a bad attack. Then this is the young lady I was telling you about who is an athlete, and this is what happens to her if her body heats up. So this is swelling of the deeper parts of the skin, as well as you can see, her tongue is quite protruding, and so that's angioedema of the throat as well and the tongue. Then if you have symptoms that are worrisome from mast cells misbehaving, do they respond to medications that target the mast cells? So now this is how we gather the story. Now we need to focus on, do we have some data that kind of help support that we have mast cell activation disorder, and I'll get into that shortly. And then once you have all of this, it's really important to make sure you don't have other syndromes that can cause this type of swelling, that can cause you to have asthma. In order to make sure that and there are other syndromes that can look like mast cell activation disorder, but are not. And then once you have kind of gotten to the best working diagnosis of mast cell activation disorder or mast cell activation syndrome, you need to decide whether it's clonal, meaning there's something broken within the mast cells, or non-clonal, meaning that there's something in the environment that's constantly or frequently tickling the mast cells to activate. Breaking down the different forms of mast cell activation disorders, so primary or clonal mast cell activation disorder includes mastocytosis, which is probably the more commonly known form of mast cell activation syndrome, or monoclonal mast cell activation syndrome. So this is kind of like mastocytosis junior, for lack of a better way. But basically it's telling me that there's something broken in the mast cell that makes them much more easily activated by non-allergic, possibly physical triggers. Then we have secondary, meaning there's something broken in the environment that we can measure. And the one that most allergists, immunologists are aware of are those that are mediated by IgE, where we're testing for either airborne, food, medication, something that you think in your environment that either you have breathed in, has come into contact with your skin, or you have ingested that may have developed, you've now produced this antibody, and every time you see it, you make more of this antibody, and it just arms the mast cells to cause you to have a much more fierce reaction the next time you see it. So we know, for instance, that individuals that have tree pollen allergy, as the spring season comes on, the amount of IgE you make goes up and up and up and up until the pollen goes away. So basically, mast cells who think pollen is dangerous because they have IgE around, they will not stop until the pollen goes away. Some individuals have either cancerous process or a primary immunodeficiency where the mast cells are now misbehaving because they feel that they need to activate getting inappropriate signals from the surrounding environment. I have several individuals that either have an antibody deficiency, a primary antibody deficiency, or a primary immune cell deficiency that causes the mast cells to misbehave. And this is kind of, so these individuals not only present with recurrent infections, they also present with allergic phenomena as well. And what I think is very relevant to this group are individuals that are very sensitive to physical triggers, like cold, heat, vibration, meaning I had one person who had this boy who used to play the trumpet, and every time he played the trumpet, he would end up with swelling in his face. I had another person who was doing some type of repetitive movement with like a blender, and her hand started to swell. So this type of physical activity will cause the mast cells to degranulate. And then we have individuals that actually develop an autoantibody that now attacks the mast cells and will cause that to cross-react. And we also have some individuals in women who develop an antibody against progesterone. And then every time the woman is going into a menstrual period, the amount of progesterone goes up, the antibody sees the progesterone, arms the mast cells, and then the person ends up being symptomatic around their menstrual period. And then, lastly, we have individuals where we just haven't figured out what the cause is. So that's called idiopathic, meaning the medical community are still idiots and we still haven't figured out what the cause is. But the individual still has evidence of mast cells misbehaving. We just haven't figured out the trigger yet. So to try to kind of review some of the symptoms and kind of give a face to the individuals that are affected by mast cell activation disorder, I just wanted to share two studies. These are individuals that are known to have either mastocytosis or monoclonal mast cell activation disorder. So there's something broken within the mast cells. And you can see in the individuals that they saw, the number one complaint was, hives, swelling, itch, or flushing. Then they would have gastrointestinal distress. And so these are individuals that actually underwent endoscopies, and unless you tell the pathologist to stain for mast cells and whether or not the mast cells are funny looking or have activation markers, you're going to miss it. And here's the interesting thing. The number 3 complaint in this patient population was neuropsychiatric, brain fog, mood disorders, not able to think clearly. And when their symptoms were not well controlled, and I would also throw in sleep disorders as well. Interestingly enough, only a fifth of these patients had full-blown anaphylaxis, something that says they have a global systemic effect. Their entire skin is involved, the gastrointestinal tract gets involved, cardiovascular compromise. People that have recalcitrant, like difficult to control peptic ulcer disease, understand that Pepcid, Tagamet, and Zantac, which is famotidine, cimetidine, and ranitidine, those are histamine blockers. So mast cells are in the gastrointestinal tract, and if they are misbehaving, they can cause a lot of heartburn, reflux, angina with certain foods that can make it worse. I would have to say I have at least 2 patients in my 2 male patients who are diagnosed with mast cell activation disorder because before the age of 32 they had osteoporosis. So if you're having issues with bone metabolism, you're osteopenic, low bone density, this is also an indication to undergo an evaluation for mast cell activation disorder. And then the difference between clonal mast cell activation disorder, either mastocytosis or mast cell activation disorder, is understand that the liver and the spleen are major immune organs. And so this is a place where the mast cells can increase in number or size and will cause your liver to get big and your spleen to get big. So it is worthwhile to evaluate for liver and spleen function and size in individuals that may be affected with this clonal mast cell activation disorder. So this is Dr. Hamilton's work, and here's the issue. This paper was done, the first author, Dr. Hamilton, is a gastroenterologist. The last author is Mariana Castells, and she's an allergist immunologist. So these 2 specialties teamed up to evaluate about 18 to 20 patients who came to the gastroenterology clinic to see why they kept on having abdominal pain even though all testing was negative. And then if you started asking some other questions, because understand that a lot of these individuals have been dealing with these symptoms for a very, very long time, and they might not think that it's helpful. So it's really important to kind of think about, am I dealing with anything else? Am I like taking over-the-counter medications to treat these nagging symptoms? Those nagging symptoms actually might be clues that mast cells are misbehaving in you. So these individuals who are coming with IBS-like symptoms to this clinic were found to have skin involvement, were found to be complaining of headache, and again, 2/3 of them were complaining of neuropsychiatric mood and cognitive challenges in the setting. And interestingly enough, when you started treating, once you got the working diagnosis and treated for mast cell activation disorder, the neuropsychiatric came under better control. You can see a lot of them had a lot of gastrointestinal distress in the form of diarrhea, constipation, or alternating. And then 39% had upper airway involvement. Another had lower airway involvement. And I have to tell you, if you have congestion issues, that is a clue that your lungs might be also involved. And they also found that a good number of them had actually had anaphylactic events where we actually had to give them a EpiPen to protect against a severe allergic reaction. So once you have symptoms that are worrisome for mast cells activating, how do you go about getting some lab data to back up what you're saying? You know, unfortunately, a lot of the medical community is, if you can't measure it, it doesn't exist. I'm saying if you ask the right tests, you will get the right answers, the lab data to back up what you're experiencing. So the first thing to look for is markers that are in the blood or the urine. So you can look for a serum tryptase. You can look for a serum histamine, but understand tryptase only is constitutively elevated in individuals that have monoclonal or clonal disorders of mast cells, so they have mastocytosis or monoclonal mast cell activation disorder. Individuals that have mast cells misbehaving because there's something wrong in the environment, this is not elevated, and I'll show you some data for that. Same thing for the serum and urine histamine. Another really effective test, which unfortunately is not available in the state of New York, but can definitely be sent out to other institutions, including Brigham, Mayo, but again, you have to ask for the test. Actually, even I send patients that come to me from Connecticut, I just tell them, please give this to your primary care in Connecticut and get that test. And I have to tell you, this has been a very helpful test in the diagnosis of mast cell activation disorder. Now, if you've undergone biopsies, whether it's of the skin, the respiratory tract, or the gut, it's really important to tell the pathologist to stain for mast cells. It's just one antibody test called CD117, which will light these cells up. Otherwise, they're like ninjas. You can't see them unless you know what you're looking for. So once you use the CD117 stain in the tissue that has been obtained, you want to see whether or not the mast cell looks odd, or what's called atypical looking cells, or whether or not they have activation markers, which really shouldn't be elevated unless they're fighting something off. So if you have cells in the organ that are positive for CD117 and positive for CD2, CD25, or CD30, these are kind of like red lights telling me that the mast cells are misbehaving, this is diagnostic for mast cell activation disorder. Now, you got the symptoms, you have some lab data. How about response to treatment? So basically, you want interventions that are known to reduce mast cells from activating. And the first thing is avoidance. And I think a lot of people kind of acclimate down to prevent cells from having reactions. You start changing your diet. You start visiting your neighbor that has a cat or dog. You start reducing your exposure to environments where you just don't feel well. I had one family actually move from their home because it was a very old home that they felt unwell in certain rooms and there was nothing that they can do about. It's amazing what people will do to try to stay well by just either consciously or unconsciously just taking themselves away from what might be causing them to feel unwell. After avoidance measures, it's the use of over-the-counter, prescription, and supplements. So The ones that are readily available over the counter are histamine blockers. So and understand that there are 4 different types of histamine receptors, and there are different medications that target the different histamine receptors. So diphenhydramine, which is Benadryl, chlorpheniramine, Claritin, loratadine, Allegra, which is fexofenadine, those are all blocked at the H1 receptor. And understand, or the first histamine receptor, and understand that what works in one person might not work as well in the other. So, and until we figure out rational drug design and metabolism, we're not going to, it's a trial and error to see what works in you. And I have to tell you, in some of the patients, they can't even use over-the-counter or prescription medications because they've all been packaged with either fillers or preservatives. So some of the individuals actually have to have the medications compounded in order to reduce their exposure. There are medications, and I have to qualify myself when I prescribe this to patients, that are used for, in higher doses, are used for mood disorders. But in lower doses, allergists, immunologists use it for controlling chronic hives and chronic swelling or angioedema, and neurologists use it for chronic pain. So I'll end up using amitriptyline, nortriptyline, or doxepin, which are very effective at working on the first, second, and third histamine receptors. We have steroids, prednisone, methylprednisolone, hydrocortisone. These just shut mast cells down. Very effective in many of the patients, but the last thing you want to do is trade in one, danger for another. Long-term use of corticosteroids are quite problematic and causing, especially individuals that have connective tissue disorders. It can mess up. You can end up with osteopenia, osteoporosis. It thins out the tendons. It thins out the skin. It can cause peptic ulcer disease or make your peptic ulcer disease worse. Or your reflux worse. It can cause mood disorders. So I use it in acute situations, but I try hard not to use that on a long-term basis. You have mast cell stabilizers, and there are 2 out there. There are the chromones and ketotifen. You have leukotriene modifiers. They're all prescription. There are 3 out there. There's one that works on the level of the receptor, so the substance gets released. The leukotrienes here get released by the mast cells. So there's a chemical that actually goes into the mast cell and shuts off the leukotriene production, and there's one that just goes to all the tissue where the leukotrienes go to block it. So that's montelukast, which is Singulair, zofilukast, which is Accolate, and Xyluton. In my office, I have the honor of working with Dr. Xiumin Li, who is an associate professor in the Jaffe Food Allergy Institute at Mount Sinai. Her area of expertise is the use of acupuncture, acupressure, and traditional Chinese herbal medicine to help reduce hypersensitivity disorders. Most of her data is dealing with food allergies as well as atopic dermatitis and asthma. And we are partnering to see how helpful this is in individuals that are affected by mast cell activation disorders. This anti-IgE antibody, anytime you see antibody as a medication, that is called a biologic. It has been designed in the test tube to soak up whatever the target is. In this case, this is an antibody made in the test tube to soak up IgE so it's not sitting on the mast cells. This is a molecule that has been indicated in this country since 2003 for the control of moderate to persistent asthma, and recently got approved for the use of chronic urticaria. So this has been a very effective molecule in a lot of the patients that I'm taking care of as well. So, mast cell activation disorder. How is this happening in individuals that have inherited connective tissue disorders? So I'm an allergist immunologist. In the past 2 years, I've learned how to do Brighton scores and Beighton scores to try to see what is going on in these patients that either have, this young lady actually was skin tested. You might see the redness in her arms here, but she had very prominent reactions, and I started asking her, are you flexible? And she started bending her arms, and her ears were very flexible, and you can see that she's doing all these tricks. And this is an individual that has a hypermobility syndrome, and she has hypersensitivity affecting her airway and her gut. So and all of you probably know this better than I'm trying to kind of catch up regarding the diagnosis of hypermobility syndrome, especially in the setting of Ehlers-Danlos. And so the next few slides are focusing on individuals that have Ehlers-Danlos syndrome. I believe Castori had published this in the Dermatology Journal, basically talking about that this is a heterogeneous disorder. And I have to tell you, I trained in some wonderful institutions. I really only started to appreciate within the past 2 years how common this is. And it really is quite underappreciated, as most of you know, by most of the medical community. And we're trying to get the word out. But here's the interesting thing. Out of all of these subtypes of Ehlers-Danlos, hypermobility, we really don't know what genes are involved. So we don't know if it's a structural protein or is it a protein that manipulates the structural proteins. They believe it's autosomal dominant because if a parent has it, it's very likely that a child would be affected as well. And it can vary in its penetration, meaning its ability to affect different children from the same parent, and also there's a difference between men and women and boys and girls. So how we diagnose it, so I walk around with this picture when I meet patients, and I say, okay, let me see your hands, and let me see your knees, and let me see your elbows, and can you do funny things with your feet, and let me take a look at your wrists and your toes, see if I can get an idea, is there evidence of hypermobility? And the thing about, and what I've learned when I send patients to geneticists, they have a tendency to just look at one or two organs, but here's the thing, you know, the score says if you have some involvement. So I've found some individuals that have more upper airway, lower airway. I just have a family member who was visiting me, and I asked, she was having these strange reactions and said she was dropping her blood pressure, and only when she went on a medication to treat attention deficit disorder did she get well. And she was at 22, she's able to dislocate both her hips. So it's really all in the story and in the history, and she's just like, she's done this all her life, and nobody ever asked her, you know, she's never been diagnosed with a connective tissue disorder. More than likely she has it. So in Castori's article, they talk about all the things that are associated with joint hypermobility syndrome, but what was really interesting in this article, and this wasn't too long ago, very little information about immune dysregulation. And in this picture, this is a mom and her son, and this son doesn't present with hypersensitivity. He presents with chronic infections unless I get him on medications to calm down his mast cells, and mom is the same. So we're going to talk about some patients that I presented at a allergy meeting last year. We wanted to see whether or not there was evidence of mast cell activation disorder in patients that had negative allergy tests but were presenting with symptoms. And so we had a total of 9 adults and children who more than likely had hypermobility syndrome. Some of them had the diagnosis of Ehlers-Danlos, others did not, per the geneticist. And so we asked them, are you symptomatic? Are you having problems with your skin, your gastrointestinal tract? Do you get lightheaded? Have you passed out? Any respiratory issues? And then we also did appropriate testing for the skin, which sometimes just involves striking the skin to see whether or not they're dermatographic or have the ability to write on their skin. Gastrointestinal distress, you know, malnutrition, not able to digest foods, diarrhea, constipation, bloating. Cardiovascular, again, lightheadedness, having runs of their heart beating fast. Respiratory distress, whether it's upper or lower airway, so congestion issues, postnasal drip, or wheezing, cough, shortness of breath. Then we use medications to target these symptoms, and we found that most of them either needed albuterol, a couple of them actually needed epinephrine pen because they actually had episodes of anaphylaxis as well. They all responded to medications targeting the symptoms, but what was really interesting when we tried to get lab data to kind of confirm the diagnosis, none of them had a tryptase that was elevated, even when they had acute symptoms. And that suggests to me that either these are mast cells that don't have tryptase, or when these mast cells are activated, they don't release tryptase. And I can tell you the allergy immunology community is quite aware of allergic reactions where tryptase is not elevated. So having a low tryptase or negative tryptase does not rule out mast cell activation disorder. And this is very common, for instance, in individuals that have food-induced anaphylaxis like my son. His tryptase is never elevated. So you have to look elsewhere to get, the diagnosis, lab data to kind of back up what you suspect. And I have to tell you, most of these patients, I was kind of like their 15th doctor that they have seen. So I ruled out carcinoid, I ruled out cancerous processes, I ruled out primary immunodeficiency. Essentially, their mast cells are broken because of the connective tissue disorder. And unfortunately, very little data has explored what is the connection between individuals that have connective tissue disorder and who have symptoms worrisome from mast cell activation syndrome. The only evidence that I have, which is really interesting, is a paper that came out of all places, Siberia. And I think there's been individuals that have talked about how the Russians screen for connective tissue disorders much more so than we do here in the West. But they showed anomalies within the mast cells that might give us a clue on what kind of crosstalk is going on between the extracellular matrix and the connective tissue and the mast cells that is predisposing to mast cell activation disorder. So in these patients that I saw, they have secondary mast cell activation syndrome, meaning they don't have IgE that we can detect either with skin testing or blood tests. They don't have other disorders that are worrisome, such as any evidence of a cancerous process or autoimmune disorder or a primary immunodeficiency. All I have is their inherited connective tissue disorder that seems to cause these mast cells to misbehave. So what's going on? And this is just my kind of like survey slate of what might be happening in individuals that have a connective tissue disorder with mast cell activation associated with it. Understand that mast cells have lots of different chemicals that they release that have the ability to talk to different organ systems. So they have direct connection to adaptive cells or cells of the adaptive immune system called T cells. So T cells and mast cells talk to each other to help coordinate immune responses. They have the ability to talk to different antibodies depending on which receptors are here. They have the ability to talk to complement. This is another protein that's very important to fighting infection. And then once triggered, they have the ability to release different chemicals that can impact on different organ systems. So they release chemical messengers that recruit in other immune cells or promote chronic inflammatory disorders, whether they're autoimmune or hypersensitivity. They have the ability to impact on the blood vessels and making them leaky. So when people talk about a leaky gut syndrome, this might be one of the factors that's contributing to that. It releases tumor necrosis factor, and understand tumor necrosis factor is very important in autoimmune disorders such as rheumatoid arthritis as well as psoriasis. They have the ability to recruit in neutrophils, and understand these cells, just like eosinophils are like kamikazes, they come in, their job is to destroy, and then they die off. And then, most importantly, in individuals that have connective tissue disorders, understand that these mast cells are recruited, have to enter into the extracellular matrix and set up shop. And they have direct communication with connective tissue. And they release enzymes that can modify the connective tissue. So the question is the connective tissue talking to the mast cells, or the mast cells talking to the connective tissue that's causing this disorder to kind of, it's like a vicious cycle that gets set up and then does not shut down unless you either fix the connective tissue disorder, which we've yet to figure out, or we calm down the mast cells. So I'm going to use this as my last slide and basically emphasize why there's such a delay in the diagnosis of mast cell activation disorder in individuals, whether it's due to primary mast cell defects or something in the environment. Well, here's the thing. If you have problems with tingling and burning or headaches, you're going to a neurologist. If you are having skin problems, you'll go to a dermatologist. If you have gut problems, you'll go to a gastroenterologist. If you're having joint problems, you'll either go to an orthopedic, a physical medicine person, or a rheumatologist. If you have a fast heart rate or you're passing out, you're going to go to a cardiologist. If you're having sinus problems or nose problems, you're going to go to a ENT. If you're having lung problems, you're going to a lung doctor. And unfortunately, medicine has been divided up like the United States along artificial lines. And because when you have a cell system that has the ability to go through all these other organ systems, and unfortunately, when it comes to education about the immune system, it's poorly taught in this country. You know, I went to some wonderful programs, and I have to tell you, if I didn't have my PhD, I'd probably be in the dark with several folks, because it's just not taught very well. And so unless you get referred to an immunologist who has an appreciation of what mast cells can do, you're not going to get diagnosed. And essentially you'll just end up stumbling upon this first family who got me thinking down this pathway. You know, it's just the ability to find somebody who's willing and able to listen to your story and then do something about it. So if you're having these symptoms, my suggestion is to get some questionnaires that addresses all of these things, and then partner up with a allergist, immunologist, hematologist, gastroenterologist, and just say, look, this is what's going on. Is there any way you can start testing me? And if you can't do it, can you refer me to somebody who can? So with that, I'm going to open up. This is just my spin on how we need to kind of go back to our roots. This is my daughter years ago in the botanical garden in the Bronx, saying there are ways for us to kind of get us back to a place where we can feel better and live better, sleep better, less itchy, and just go along this journey with less pain. But thank you for your attention. I appreciate it.
Well, thank you, Dr. Maitland. That was very informative, a lot of good information that we received there. We'll have to listen to that again and get the details. But you're free to go to the Q&A box now and read those and answer them.
Okay.
Thank you.
Okay. So the first question is from Louise regarding alternative treatments to antihistamines. There are lots of different treatments that are available to treat, and it really needs to be tailored to you. Some individuals actually have metabolism issues when it comes to medications, and that is now, we do have the ability to kind of diagnose that. I would recommend you partnering with someone who has knowledge about the different types of medications that are available. There are ketotifen, there are leukotriene modifiers. You know, here's the thing about Dr. Lee. She actually does telephone consultations, and she's happy to get on the phone with you and talk to you about her use of acupressure. And I have to tell you, acupressure and acupuncture has been extremely effective for a lot of these patients as well. The use of omalizumab, which is, in this country, it's called Xolair, to try to help get these symptoms under control as well. Looking at your diet is important. Looking at your airborne environment is important. So that's what I would recommend first. the best way to address this is really to kind of partner with a doctor who can walk you through the pluses and minuses of whatever they recommend. And then there's also recourse and trying to tailor it to you. And also another thing I would ask is looking at why you can't tolerate the antihistamines, and maybe there's a way of adjusting that regimen to see that you better tolerate it. I'm moving on to the next question. Wow. Okay, so this is from the UK regarding having other disorders that can make whether or not there's a relationship between other disorders and mast cell activation syndrome. So this is whether or not there's a link with a condition which also is of unknown etiology called sarcoidosis and mast cell activation disorder. I would have to say we don't know. But here's the thing. Sarcoid is considered a monocyte macrophage disorder, and there has been some recent evidence, I believe, coming out of University of Tennessee that sarcoidosis may be due to a infection that just has not been appreciated of a really ancient organism, a mycobacterial. And it seems that if you're able to calm down the inflammation with sarcoidosis, you may be able to calm down mast cells. And I'm going to say that we have seen in other inflammatory disorders such as rheumatoid arthritis, mast cells get drawn in because it's a site of active inflammation. So if you have active inflammation, it is very possible that the mast cells can be basically are responding. Think of if you have a fire. You know, it's all hands on deck, and then you kind of sort out who can help and who you can't help. But unfortunately, there might be something going on in you to tell the mast cells you don't need to participate. So yes, I do believe there might be a link. I just don't think it's been established. Okay, this is from Rosemary talking about EDS and MCAD. What specialists should I have on your team? Here's the thing. In the U.S., and I'm assuming, Rosemary, you're here in the United States, EDS really is, I appreciate the frustration of having the diagnosis EDS, and I definitely appreciate the diagnosis of mast cell activation disorder. What you need to do is work either with someone who's familiar with it, and the best way to figure that out, I would recommend that you go to one effective site to identify individuals that have who have expertise in mastocytosis or mast cell activation disorder is the Mastocytosis Society. They have a lot of references, and they also have investigators who are very active in the care of patients that are affected with mast cell activation disorder. And then here's the thing. It's going to be a team where you have a co-captain. And my suggestion is either when it comes to the hypersensitivity disorders, you really need to work with somebody who understands how immune cells work or how mast cells work. So I would encourage you to go to the mastocytosis site here in the United States. There's also a Mastocytosis Society in Canada as well. I'm not as familiar in New Zealand and the UK, but if you contact an allergist immunologist and say, look, this is what I've been diagnosed with, you can see if they can partner up. And I have to tell you, what I've done is I've just partnered with other allergist immunologists across the country, and most of them are quite open to suggestions and are willing to reach out and partner up and be informed. And here's the thing. You can always have a telephone consultation, for instance, if you can't get to any of these mast cell activation disorder experts. And then they can also send the information to a local allergist, immunologist, who can partner up with you as well. Other people who have shown some expertise with mast cell activation disorder is Dr. Theorides, who is a pharmacologist, as well as William Afrin, who is a hematologist. There are 3 sites for mast cell activation disorder that I can share with you so far. There is at Brigham and Women's, that's run by Kim Aiken, as well as I just lost my program again, but Kim Aiken and Mariana Castells. I have to reload. I'm sorry, John. I'm going to see if I can get it over here. Oh, Ashugana. It's rebooting. As well as National Institute of Health, there is Josh Milner. There are some other people who have shown expertise and are just willing and able to learn, understand, just like that patient has, when I first met, said they're willing, they're going to, they stumbled onto me, and honestly, I just started reading and thinking and started listening. That's when, it's not showing the questions anymore.
Okay, I could attempt to read the questions for you.
Okay, that's fine.
Okay. I'm trying to figure out about where you are here.
I was talking, I believe Rosemary was asking about what teams.
Yes, team managing me. Okay.
Right.
And let's go to the next one. Can mast cell activation syndrome cause severe abdominal bloating?
Yes, most definitely. The largest collection of mast cells outside of the bone marrow is the gastrointestinal tract. So the only way to really diagnose it is either using medications that target the mast cells, or undergoing an endoscopy, or if you've undergone an endoscopy and they still have slide blocks, you can have those slides stained for mast cells to see whether or not they are misbehaving or not. Also, it's really important to just check some serological data. You can check to see whether or not you have an elevated IgE, if you have an elevated tryptase, elevated prostaglandin D2 level, or elevated histamine level, either in the serum or the urine. So most definitely.
Okay, the next question is mast cell activation syndrome ruled out if you have type 2 diabetes or multiple sclerosis, or can MSAS be part of these illnesses?
I have at least 2 patients in my practice that have multiple sclerosis and have misbehaving mast cells. So understand that mast cells have a job to do, and they have a tendency to jump in if they see something's going wrong. So it's very possible in the process of an autoimmune disorder like multiple sclerosis, mast cells might be misbehaving and contribute to symptoms such as gastrointestinal distress, skin, itchy skin or flushing. I have one person who actually has a condition called collagenous colitis and another one who has inflammatory bowel disease, and she definitely has mast cell activation disorder in the setting of having this other autoimmune disorder. So yes, it definitely can happen, and it is not ruled out. The definition of mast cell activation disorder just tells me that you are having symptoms and mast cells might be contributing to it. That's it. Whether it's due to you just having IgE to pollen or foods, or you have you have a connective tissue disorder and it's causing the mast cells to kind of be on DEFCON 3 all the time instead of resting on DEFCON 1. You might be predisposed because you have another secondary, you have another immune disorder, whether it's an autoimmune disorder or an immunodeficiency. So yes, it is a possibility.
Okay.
You can direct me to the next question. I can ask it for her.
Okay. Regarding GI symptoms, would you consider?
Okay. Would you consider difficulty voiding a mast cell reaction? The comment is that can't start, stream, or can't empty dribbling.
I would definitely want to evaluate for structural abnormalities first. It depends. I don't know if this is male or female, but it's
female.
You can. There is pelvic dysfunction in the setting of. I've had some people have pelvic dysfunction, and also they can have neurological sequela. So if you have any issues with, first I would rule out, is there any strictures? Next thing I would want to rule out, is there any evidence of inflammation in the urethra or the bladder? I also want to rule out whether or not there's any neurological phenomena, because some people who have any structural problems in their spine can also contribute to that as well. And then if you're taking antihistamines, it depends. You really need to kind of take a step back and have somebody go through the different etiologies of causing that symptoms, and also see whether or not there are any other comorbidities. That is an unusual presentation for mast cells. I'd be more worried about another etiology, and that would be kind of lower on my suspicion list.
Okay. The next question is asking if there is a list of doctors who could test and treat MCAs, if there's, for people in different areas of the country. Is that?
I've had conversations with doctors in Arizona, in California, Texas. I think it's slowly getting out there. I had a conversation with an allergist who's in Bucks County, Pennsylvania, and the Pennsylvania Allergy Immunology Society just had Mariana Castells come talk there, and he's like, and we now have a patient in common, and he's like, you've done everything, I'm just going to continue to monitor. And that's what I meant by, I think it's important to kind of get evaluated by somebody who has some expertise in mast cell activation disorder, and they can partner with a local allergist immunologist and share their expertise. Here's the thing. A doctor will either be willing or able, and their job is, if they feel that they can't do it, then they're going to try to reach out for help. Mast cell activation disorder is a chronic condition, and that means you need to have a medical home for that. If you're having mast cell symptoms, it's really important that somebody who's used to using all these different medications, able to see whether, what works in you best, and also monitor for side effects that are associated with these medications. Step up as you get worse, and step back as you come under control, because you don't want to be on medications longer than you have to. I would encourage you to go to the Mastocytosis Society page here in the States, and they list providers in several states. I do, if you're not in New York, I do telephone consultations. Feel free to give my office call. I know that Dr. Aiken and Dr. Castells are accepting new patients as well. Josh Milner, it's been a little bit tricky because he has, the NIH has gone on sequester a few times with the budget, but he's also open to it. He's very interested in understanding what's going on there. William Afrin is another one. Dr. Theorides is another. There are more and more physicians who are accepting of this. And not only in allergy immunology, but like I said, hematology as well as gastroenterology. I just partnered with another gastroenterologist who's like, okay, this makes sense for a lot of my patients, and now she's going to start looking. So, but it starts with finding somebody who's motivated and willing to work with you. And I would, again, encourage you, feel free to contact my office or feel free to go to the Mastocytosis Society page. I think it's tmscure.org for physicians who have expressed interest and have declared expertise.
Okay. The next question asks about a supplement which basically has diamine oxidase in it, and the patient feels it helps her. She wonders if you have heard anything about this particular supplement.
That supplement basically is an enzyme that helps break histamine down, and I can understand it being quite helpful, but sometimes it might need a little extra help because histamine is not the only thing that gets released by mast cells. I think as long as you tolerate that, there's also other supplements that have been recommended, including quercetin, vitamin C, and then, like I said, the herbs one of the herbs that Dr. Lee has been using, and I'm going to defer to her because she has been studying these herbs for the past 20 years and has been using them with a lot more frequency and has published the data. So there's definitely a role for using any means to reduce the effects of excessive histamine release. And so that supplement just breaks the histamine down so it can't act on target organs and cause you to be more symptomatic.
Okay. A patient asks if you are accepting new patients at this time.
I am. I am. My office manager, if she's online, is probably gonna, okay, hold on. Yes, I am accepting new patients, and I'll leave my contact information with your group. So.
Okay. And can you discuss how MTHFR might relate to the topics that you discussed tonight?
That's a really interesting question. Everyone's asked some really provocative questions. I don't mean to do that, but I have to say that we don't know, generally speaking. But understand that gene is responsible for oxidation and breaking down radicals. Remember what I was saying before that that mast cells can respond to physical triggers in the environment? That includes chemicals. If you have a abnormality in that gene that doesn't allow you to metabolize as efficiently, you might have an environment that causes the mast cells to be a little bit more twitchy because perceiving more pollutants in the air. So it's kind of like, you were living in bucolic Connecticut, and then you moved to the middle of Times Square. There's just too much irritants around there, and that just causes the mast cells to be more active, is what I suspect. But there's no data up to this point to back up that suspicion of mine.
Okay. You were mentioning cardiac symptoms in relationship to MCA disorder. And in some cases of dysautonomia or POT symptoms, could the root cause be mast cell activation disorder resulting in dysautonomia? Or should all dysautonomia patients be tested for MCAs?
I think, first of all, I don't know what's the chicken or what's the egg. We do know that mast cells, first of all, both mast cells and nerves are sources of histamine. Secondly, we do know that nerves do talk to mast cells. And I've had individuals who have had near syncopal episodes, near fainting or fainting episodes, who've had runs of tachycardia, and they had a condition, a neurological condition that was predisposing them to mast cells being more active. So I think it is definitely worthwhile to evaluate it, because if we can either modify your environment, which you eat, breathing conditions, and what have you, get you on a regimen that is able to stabilize the mast cells, that might be helpful for you controlling the the POTS or the neurocardiosyncopy or vascular insufficiency. Understand, though, that individuals that have connective tissue disorders also may be predisposed to peripheral neuropathies, including affecting the peripheral nervous system that talks to the vasculature. So, you know, it's a complicated system, but I would say the short answer would be, I think there's no harm, and there might be a big upswing or benefit if you get evaluated for that and then start targeting treatment that helps you with that.
Okay, the next question. This patient was prescribed a cromolyn spray in the past and ended up getting a very bad migraine afterwards. Is that common?
Yes.
Does that mean that they're allergic to the substance that's supposed to be helping?
I wouldn't say allergic. Because allergic implies having IgE to it. I would use the word intolerance. Understand that I've seen people have intolerance to steroids. I've seen people have intolerance to antihistamines. I've seen people have intolerance to cromolyn. Yes, I have seen this before, and the simple answer is stop the medication and look for another intervention. I've seen people get worse on gastrochrome. Understand we have cromolyn preparations that can be ingested to help with gastrointestinal distress, that can be sprayed into your nose, which is over the counter, that can be inhaled for your lungs. Cromolyn was a mainstay for pediatric asthmatics or children with asthma. Any medication, there is a bell curve, and some people have a small therapeutic window, meaning, you know, just a little bit will help, anything more will make it worse. And some people have a wide therapeutic window, meaning they can do 4 sprays of cromolyn to the nose and not have a problem and it be beneficial. Most of these medications or any intervention, there has to be expectations on when the medicine is supposed to work and common side effects. And that is not, I've had several patients that do not tolerate cromolyn.
Okay. Next question, how do you treat inflammation due to MCA? Is osteoporosis due to MCA treated the same way as regular osteoporosis? And what about side effects of these medications, since we are more sensitive and usually get more severe side effects?
There are people that have osteoporosis and MCA and do well with medications targeting the osteoporosis. There's some individuals that don't tolerate those medications and need to either use other preparations. Understand that there are different medications that are used for osteoporosis besides medications like Prolia and I'm blanking on a lot of these, what they call bisphosphonates. These bind the bone so the immune cells don't modify them. Again, I would really encourage you to partner with an endocrinologist who will also partner with an allergist immunologist to kind of tailor a medication that works best for you. You want to make sure that the osteoporosis is not from a monoclonal mast cell activation disorder, like that is not mastocytosis or monoclonal mast cell activation disorder, because the treatment is very different than if you have a non-clonal mast cell activation disorder. So you need to look at the etiology of the osteopenia and osteoporosis. And then once you look at the etiology, you want to calm that etiology down while you help strengthen the bones. So that is a real concerted effort. And in your team, like I said, it needs to be an endocrinologist and an allergist immunologist or hematologist, somebody who's just knowledgeable about the use of medications for the mast cells. We actually have some people where we actually do desensitization to the medication so they better tolerate it as well. So.
Okay. Next question. If somebody develops a dangerous sensitivity to antihistamines, although they are working for them, is there another treatment available? For example, this patient can take 1 to 2 Benadryl a day, but any other antihistamines will give a violent gastrointestinal reaction.
Yeah, there are other. First of all, there are other antihistamines available. So let me talk very briefly about the different types of histamine blockers. So there are 3 generations of antihistamines. First generation, like Benadryl, chlortrimeton, hydroxyzine, they're the ones that are the oldest. They work differently. Some people get very agitated. Some people get worse. They have a tendency to be short-acting, but they're the most potent if you're having an allergic reaction, but they only last 4 to 6 hours. There are second-generation antihistamines, which have been such as the Claritin, the Allegra, and the Zyrtec, which last 24 hours, are not as effective as blocking histamine, but they're less sedating and less likely to cause things like constipation and what have you. And then you have third-generation antihistamines like Clarinex, which is desloratadine, and levocetirizine. There's some people who don't tolerate the histamine blockers at all, so I end up actually using medications like, by the way, cyproheptadine, which is also a first-generation antihistamine, also called Periactin, works very differently than Benadryl or chlortrimeton and seems to be somewhat better tolerated than Benadryl or diphenhydramine. Then there's the use of other medications, for instance, the amitriptyline, the nortriptyline, and the doxepin all have the ability to work on histamine receptors and not the same way as the traditional histamine blockers that I just talked about. You also have the use of mast cell stabilizers such as catodafin as well as the chromones. You have leukotriene modifiers. You also have these herbal preparations such as the histamine enzyme DHAO, or you also have the use of omalizumab or the Xolair. There's lots of things out there. It's a question of partnering with somebody to say, okay, let's try this. These are the classic things that you need to watch for, and then if it doesn't work, then we'll modify it. Also, some people might have to have their medications compounded because it might not necessarily be the medication as opposed to a preservative or binding agent that's in there. A lot of individuals that have mast cell activation disorder have a lot of intolerances to milk and wheat and soy, and so then you have and understand that a lot of these medications have lactose as a binding agent or soy as a binding agent, and that might be what's problematic as well. But in the end, it's a question of you partnering with somebody who believes you, who's going to work with you, and then try to change it up a little bit, and realize that histamine is only one of the blockers, is only one of the therapeutic targets for helping getting mast cell activation disorder under control.
Okay. Next question, just wanted to refresh their memory. What is the name of the test that you said was most effective but was not available in the state of New York?
That's the prostaglandin D2 and prostaglandin F2. These are breakdown products that are generated in cells, and honestly, it can be ordered through LabCorp or Quest, but just not by a New York State physician, and I couldn't tell you why. But it can be readily ordered by everybody else besides myself in order for the insurance to pay for it. And it's not an inexpensive test, so I would really encourage you just to partner with a physician outside of the state of New York who could order it.
Okay. And let's see. Sorry, I didn't understand that question. It says, I feel much better with an ocean breeze. Does salt air calm down mast cells?
Well, I had to tell you, somebody just asked a question about cyproheptadine. So I have to tell you, I have a lot of folks who use either Epsom salt baths, saline,
for the nose. I have individuals that use Calm Magnesium. I think the connection might be the nerves and the mast cells. But yes, it has been shown to be effective. There are several companies. If you went into a pharmacy 15 years ago, you would never see a neti pot except for in like health food stores. Now it's kind of like mainstay. Salt water is very helpful in many ways, and it'll definitely be worthwhile. I'm a big fan of recommending not only Epsom salt baths or Don Burrows powder, which is another salt. I also am a big fan of recommending contrast showers if you can tolerate it.
Okay. This person is wondering, can IVIG help with mast cell issues?
I would only recommend that if you have either a neurological disorder or a primary immunodeficiency that would warrant that treatment. That's not a benign treatment. I'd almost would argue more for Xolair if that's a more appropriate treatment. But it all depends on what is the etiology of the mast cell activation disorder, what is causing your mast cells to misbehave. So immune dysfunction, whether you have an autoimmune disorder, whether you have a primary immunodeficiency or a hypersensitivity, meaning too much IgE running around, you need to target that etiology. So unless you have a neurological disorder or a primary immunodeficiency that would warrant that treatment, I would not recommend it. And that's not a benign intervention.
Okay. This question, my naturopath has prescribed sublingual allergy drops for food allergies. What is the effectiveness of this treatment, and are there any pros or cons?
There's pros or cons no matter what any healthcare provider recommends to you. There should be evidence that you have, first of all, in the U.S., the only sublingual drops that insurance will pay for is grass or ragweed. And there's not enough data to answer that question in this country. What I can tell you is that individuals that have, I am trying, because omalizumab, which is used for allergic asthma as well as chronic urticaria, has been shown to be effective, there's a possibility that it can help. They've looked at allergy drops, they've looked at allergy shots to see if it helps with certain forms of food allergies, and it depends on what you're allergic to. It has been helpful in some and not in others. So that has to be a more tailored, like, what foods are you allergic to? What was the testing like? You know, what kind of drops are they giving you? And then when they gave you the drops, there should be expectations on when you should see improvement. And I don't know whether or not there's enough data to support that. I've seen improvement of food allergies with the use of omalizumab. I've seen improvement of food allergies with certain foods such as milk and egg, where there's data on how to desensitize somebody to that. I'm not too sure, depending on what food allergy you're talking about, and that really needs to be a question that's addressed by whoever prescribed the drops to you. There should be, if this is not, you know, an FDA-approved drop, then I don't know if there's any data to support what the person is giving to you. Like I said, in this country, the only tablets that are available are for ragweed and grass. There are definitely food allergies associated with ragweed and grass. There's no data in this country that supports or denies or refutes whether or not sublingual treatment of food allergies with whatever drops they're giving you is going to be beneficial. So I would revisit that with the person who prescribed the drops to you.
Okay. This question says, my husband has EDS and was recently stung by bees but had a different reaction than he had before. Can MCA happen spontaneously or happen suddenly after years of not having problems? And because the kids have EDS as well, does that mean they will have MCA as well?
Well, it's important to evaluate for MCA just by symptoms-wise. If you have unusual reactions to insect stings, it's important to see whether or not it was anaphylaxis or not. And anaphylaxis, like I said, can either have neurological phenomena, gastrointestinal distress, respiratory distress, cardiovascular distress. And here's the thing, you can be allergy test negative and still have that sensitivity. And if the children have EDS and also are showing symptoms that are worrisome for mast cell activation disorder, meaning, again, they're having like hay fever, allergy-like symptoms, they have asthma, they have hives, they have gastrointestinal distress, they have food sensitivities and medication sensitivities, it's definitely worthwhile to have them undergo an evaluation for the possibility of mast cell activation disorder, because we do know that individuals that have mast cell activation disorder are at increased risk for having a severe reaction to insect stings, and appropriate treatment should be pursued.
Okay. Next question. With regards to what you were mentioning about corticosteroids and negative effects on EDS patients, is it only the glucocorticosteroids or also mineral corticosteroids? The patient mentions they're on Florinef, which is a mineral corticosteroid, and is this particularly dangerous in light of the EDS?
It is the glucocorticosteroids that have been known to have more of a prominent effect than the mineral corticosteroids. There is some cross-reactivity. It depends on, and whoever prescribed that to you should have advised you of short-term effects to worry about and long-term effects. And if they prescribed a medication to you like that, there should be expectations on whether it's helpful to you or not. It definitely has a tendency to raise your pressure, but that's the job of the mineral corticosteroid, is for you to hold on to salts so you can maintain your blood pressure and be less susceptible to episodes of fainting or near fainting or POTS-like symptoms. I would encourage you to, as I do with individuals that are on glucocorticosteroids, that you should undergo eye exams. You should make sure you're not having reflux symptoms. I don't think there's as much evidence for that affecting the ligaments and the joints, but I'd have to review that. Offhand, that does not cross my mind, but I can follow up with that, or you can follow it up with the person who prescribed it to you.
I just wanted to do a real quick time check. It is 9:35 Eastern. We have quite a few questions in here, and I don't know that you're going to have an opportunity to answer all of them. But what I'd like to do is go for another 10 minutes. Would that work out for you, Doctor?
Sure, that would be fine.
Okay. And I apologize for all those that we didn't get to your questions, but there's over 50 questions in the list, and this is probably a record for the number of questions we received. So we appreciate that as well. So go ahead, Deanna.
Next question. I have many symptoms of MCA. Could a malar rash on the face be MCA related rather than rosacea?
It's going to be interrelated. Mast cells are definitely involved, and some people can be, the rosacea can be exacerbated by mast cells being recruited in. It doesn't happen with everybody. Treatment is mostly targeted at controlling the vascular component, but understand that mast cells can directly talk to the blood vessels that are contributing to the rosacea as well. So true, it is related, but treatment is more focused on the vascular component than it is on the mast cell component.
Okay. This question asks, is it possible that the misbehaving mast cells are actually causing abnormalities in connective tissue rather than the connective tissue causing the mast cell activation?
Good question. Chicken or the egg? Understand that one of the enzymes that seems to be problematic in mast cells that individuals have that connective tissue disorders is chymase, and chymase can affect connective tissue. Don't know. That's, the problem in this country is EDS is really underappreciated, and mast cell activation disorder is really underappreciated. We have 77 programs of allergy immunology across this nation, and that's a specialty that's underserved. And out of those 77 programs, there's only 2 programs that talk about mast cells or research it. Maybe 3 if you want to throw in Dr. Theoridis, who's actually a pharmacologist. We're looking into that. I've actually partnered with, but this is hindsight, I'm partnering with an ENT at Mount Sinai so we can start looking at individuals and start screening for connective tissue disorders in individuals who are presenting with rhinitis as a manifestation of mast cell activation disorder, so we can start looking at the tissue before early on. But I think the only way we're going to be able to answer that is to try to evaluate children of adults who have EDS to see whether or not we can see abnormalities in their mast cells beforehand. I suspect by the definition of mast cell activation disorder, we don't see we see changes in the mast cells in patients that have EDS. It's just a question of, are those changes causing the connective tissue disorder, or is the connective tissue disorder causing the mast cells to upregulate that enzyme or other enzymes that we don't know yet? So.
Okay. And somebody asks, are antihistamine diets worth trying?
Oh, I you know what, definitely. But you don't want to, you know, there's a huge argument in the community on what is a low histamine diet. I have patients that have aspirin allergy along with, or nonsteroidal anti-inflammatory allergy along with mast cell activation disorder, and they swear by lowering the diet, but understand there's a huge social capital by maintaining those diets. So typically, there's certain foods that are just high in eliciting histamine release, not only histamine release, but other factors from mast cells. And there are foods that are known to stabilize the mast cells, like pomegranates, in some people. So if you're going to pursue a histamine low diet, I would expect you to see improvement within 2 weeks. If you don't see improvement within 2 weeks, I don't know if that's going to work for you. You also want to make sure that you're not nutritionally compromised. I have one patient who actually developed scurvy because she was avoiding so many foods. She's now vitamin C. It's undetectable. So you need to be careful about that.
Okay. Is there a mediator for temperature intolerance?
Ooh, probably. My suspicion it's one of the factors from the mast cells that directly talks with the nerves. We know that they're able to elicit neurotropic factors or histamine-releasing factors from the nerves that will cause the mast cells to degranulate. But interestingly enough, the treatment is the same.
Okay. Are there precautions to take if you have mast cell and are having future surgery?
Oh, yes. Oh, yes. And again, you can go to the mastocytosis site. They actually have a protocol for going to the emergency department and also undergoing surgery, saying there's certain medications you should definitely avoid, and these are medications that have generally been shown to be safe. These are recommendations, ideally, and I would strongly encourage, this is a list that you need to go over with your allergist immunologist.
Okay. Are there any medications known to cause MCAs?
There are medications that are known to cause direct mast cell activation. Vancomycin, radiocontrast material, certain anesthetics that are used for local as well as general anesthesia for procedures or surgeries. Polymyxin will do it, which is a topical antibiotic. Those are just some that are just known to be, go straight to having a reaction. So having mast cell activation disorder just tells me that you're predisposed to being much more sensitive to things that you eat, ingest, changes in the climate, things that you apply to your skin. It doesn't tell me why. But once those mast cells are sensitive, it just tells me you have a lower threshold to be kicked off by either certain foods, certain procedures. For women going in or out of your menstrual period, I mean, and thyroid disorder is also implicated in it as well. So.
Okay. This patient says they hit a plateau suddenly with their allergy shots not working anymore after taking them for 9 years. Her allergist ended up having to double her dose. Could MCAs be a culprit in this situation?
Yes. Yes. And here's the thing. When you're using allergy shots, you are solely going after the IgE pathway. You're not necessarily going after other things. And I think it's really important to kind of make sure you've ticked off, you want to make sure, well, first of all, it depends on why you put on allergy shots for the first place. Is it a question of sinus infections or asthma or atopic dermatitis? Those are the indications for allergy shots. And then if you're having symptoms, you want to make sure that this is not just hypersensitivity. Again, I really encourage if you're having recurrent respiratory infections or recurrent asthma exacerbations, it's really important to make sure that you don't have an immunodeficiency, or you might just benefit from beefing up the part of your immune system that's responsible for fighting off infections as well. So I would look for other etiologies as opposed to just doubling down on one therapy.
Last question, Deanna.
Okay. Do you treat patients who have severe MCAs, meaning at least weekly anaphylaxis requiring epinephrine and other rescue meds, in addition to being on a lot of big gun mast cell medications?
Yes. Yes.
Okay.
Yes. I'm rather dogged. My approach is, my job is to present to you all that's available, and let's see what else, for instance, I don't know if you're on Xolair or not. There are other treatments that are available. Again, it's figuring out what version of MCA do you have, and what are you taking? Are you being appropriately dosed? I've met people who were on Xolair and they were not given the right dose. I mean, there's a lot of questions that need to be asked. And again, it's figuring out the etiology. What are you trying? And then what else can we do to try to help get things under control? So. And also, I'm not the only one. Just to let you know, Dr. Aiken and Dr. Castells are wonderful. They also have a great center, as well as National Institutes of Health down at, for the pediatric side is Melody Carter, and on the adult side it's Josh Milner.
Okay, and this particular severe patient mentions Gleevec, benzos, SNRIs, and antihistamines.
Yeah, there's a few medications she's not on, so I would definitely recommend a second evaluation. And like I said, Boston, New York, or NIH down in the D.C., Maryland area.
Okay. And the last question I got from several people was about your new pamphlet, Mast Cells Gone Wild. Is that available yet at this time?
I am on the 4th chapter. I have 2 more chapters to write. It's just been extremely crazy. I'm hoping to have it done within the next couple of weeks. And what I'll do is, if it's okay, I'll send you a link. We're going to put it on Amazon, and also we'll be able to send it out.
We'd love to put that link on there for you. At this time, we really appreciate you going over and the time and answering all these questions. It's been very valuable to all of us. So thank you very, very much for your care and concern for us is very evident, and we really appreciate it.
My My pleasure. I hope it's been helpful, and just to let you know, it's all about connections, and also just letting you know there are people out here who are trying. You just got to be patient with us as well as with yourselves in trying to get better.
Okay. Thank you for your expertise.
Yeah, thank you very much, and I appreciate everyone that's attended this evening. We had a record number, over 100 people attended our session, and it will be recorded and posted, or it is being recorded and posted on our site. I wanted to remind you that we will be having another session on the 20th. That'll be 2 weeks from tonight. That'll be Dr. Barnum. So please attend that. If you'd like to be on our mailing list for future sessions, request a free report on our site at edsawareness.com, and we'll keep you up to date on the future sessions. So thank you again for everyone that's attended, and thank you, Doctor, for a very informative session, and we'll call it an evening. So thank you.
Have a good evening.
You as well.
Good night.
Good night.